Documentation of care, submission of services, completing the advanced beneficiary form. We are talking about the same requirements. Remember what I said about railroad Medicare? Railroad Medicare, you can always tell they have a different, they actually have an alpha prefix. Same rules. United Mine Workers, exactly the same documentation rules. The only difference is they pay better. They pay better and they pay more. Medicare Advantage, who has a Medicare Advantage? Is anybody here hear of or familiar with Medicare Advantage? Exactly the same documentation requirements. Exactly the same. And they can pay better. Frequently, they will pay for x-rays or exams or therapies. Now, it might be that they don't understand they don't have to. I don't know. But that's what actually goes on. Modifiers for care, when you give a CPT code like a 98941, if it's active treatment, say it's active treatment in AT. That is a Medicare benefit. GY means the item or service is statutorily excluded from Medicare. GY, do they treat us like this? It's true. And a GA, an ABN has been signed because it'll be rejected by Medicare as not medically necessary. How do you just know what's medically necessary? Local coverage determination L35424. Now, everything that I'm going over here, I'm making it easier to see, but it's all in those SE160 references that I have in your notes. For anyone that, I didn't see anybody writing furiously, but just in case you were thinking about doing that. Medicare Benefit Policy Manual, published blah, 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 Section 240. The Medicare Report, it's published 4 times a year. You can get it online, or you can ask for it from your Medicare area carrier, Palmetto GBA. All you have to do is call and ask. They can't deny you. The Medicare AB Reference Manual. In my area, you can get all this information at novitussolutions.com. In yours, it's palmettogba.com. And when you get a Medicare explanation of benefits, it'll have an 800 number on it. That's how you can call and ask for these references. This is Pennsylvania. You'll have to go to your local to make sure that the next one. What is medically necessary? You have to have a significant health problem. It has to be neuromusculoskeletal. The manipulation must have a direct therapeutic relationship and provide a reasonable expectation of recovery or an improvement in function. Do they have to get better? No. No. They still cover as long as they improve function. And they must have a demonstrable subluxation of the spine. How are we going to demonstrate that? Before 2000, we did it by x-ray. It was required. After that, they go by physical exam, the PA-RT. They have 2 types of subluxation. You must diagnose this on the very first visit. Is it an acute subluxation or a chronic subluxation? This is their definition. Use your clinical judgment. This, having an improvement or at least a rest in the progression of the patient's condition, a new injury is generally a shorter length of treatment. Chronic subluxation will not significantly improve or be resolved with further treatment, but it can have some functional improvement. Not as intensive care, but over a longer period of time. What is not medically necessary? Maintenance therapy. Is this the greatest definition in the universe? Services that seek to prevent disease, promote health, prolong and enhance the quality of life. Doesn't that sound great? In box number 2 on the ABN, and box number 2 of the ABN, you can have these exact words when they say, I'm going to pay cash for this, and I understand it's not a covered service, that it's maintenance. Clearly document if there's an exacerbation. They pay for exacerbations. It's easy to document. They're being treated and it flares up. That's an exacerbation. Write it down. Give them a whole new date of injury. Add a diagnosis code if it was from a sprain or strain. But clearly document because they want to know. If it's a recurrence, what's the definition between an exacerbation and a recurrence? Used to be 30 days of not having symptoms. Now it's 90 days of being quiescent. because I kept saying quotient or something like that, because they changed the definition. Luckily, I had a chiropractor that was a retired English teacher, and he let me know that it was really quiescent during a break, because he was too shy to tell me while I was lecturing. The phase of care has to be in your notes. The month of treatment, or easier to keep track of, how many treatments for that condition since the date of the first treatment. So the phase of care, not according to Easy Rickman, not according to the crazy French guy in Arizona, I forget his name right now. He did the, Bruno, Uno? Not according to him, not according to Deed Harrison. Their definition of the phase of care, how many treatments, Arnaud Bernier, how many treatments for that condition. And you put the date of first treatment in box 14 of the HCFA. You must have an ICD-10 code that demonstrates medical necessity. If they don't have a subluxation, it's not a covered service by a chiropractor. So what's the primary diagnosis? M99.0. 01 means cervical, 02 is thoracic, 03 is lumbar, and 04 is sacral. 05 is ilium. The documentation may be a valid x-ray or by a physical examination. The date of the x-ray must be in block 21 when you send in the HCFA form. Now, if you don't have a valid x-ray, you have to go by the PART of the physical exam. Pain, asymmetry, range of motion, tissue and tone change. Secondary diagnosis code. A complaint code. It has to be listed on the LCD. If it's not on that list, it's not medically necessary. You can prove medical necessity, but you have to send in all your notes and exactly why. Almost always, that condition is found on the LCD, the local coverage determination, the ICD-10 codes. It used to be 44 codes. Now, oh man, how many is there? How many are there now? It's more than 140. It's a lot more to keep track of. But they go in groups. Group 1 is basic pain codes, condition codes, and that's good for 12 visits. Group 2 has more of the sprains and strains, and group 3 you get closer to neurological. These codes will give a clue as to whether they're acute or chronic conditions, but you want to have it written out in your notes. What's reasonable and necessary? 12 services in 30 days, so 4 weeks of 3 days a week. If you go more than 12 in 30 days, that's not reasonable, and they'll deny. Or 30 visits in 365 days. Can you tell one leans more towards acute and the other leans more towards chronic? The 4 diagnostic groups each have a certain number of visits that they're worth, and it's not expected to be substantially more. Who makes that determination? You appeal it, eventually go to an administrative law judge, and they're generally very liberal. If 30 visits are used for Group D, that's the one that has the most neurological involvement, they would consider that as the maximum number for the year. Without an exacerbation or without complication, that would be the maximum number. Group A has 12, Group B has 18, Group C 24, and Group D will be 30 manipulations. Group D is much more likely to have very strong sensory problems, disc involvement, disc and neurological involvement. Documentation requirements. How is it medically necessary? It has to be documented to be medically necessary. This is a burden, but not more than we can handle. My screen bean, I think, says it all. How do they know that you've documented everything? When you put a date in box 14, which says date of illness, injury, or an LMP. But don't put in the date of illness, don't put in the date of injury, don't put in the date of LMP. Put in the date of first treatment if you're a chiropractor. Chiropractors only. When you put a date in there, you agree that it's medically necessary. You also agree that all the documentation requirements, not only are they met, but they're available on review. On request, I'm sorry. If they ask you, if they request the notes and you don't send them, the next year you will be asked for your notes before they'll pay you. Every visit you'll have to send in your notes. Legibility. You have to have the patient name, date of service, the clinic, the person providing service, and sign your name. Don't just initial. If you initial or you don't sign your name, they get the money back. How much money back? All of it back. Let's say you're a resident in nephrology and you've done kidney surgery and you're a resident, and all through your residency you wrote your initials in because that's what you were taught. And then at the hospital, for those surgeries for the last 3 years, you only put in initials and you didn't write your whole name. How much of that money given to the hospital and to you did Medicare get back 3 years running? Hundreds of thousands. Because in the medical field, they're not used to doing their whole name or legibly. So I will tell you, they're not really going after chiropractors. All right, we can get $32.33 back from Powderly, or we can go to a surgeon and get back $36,000 at a time. But do it anyway. Sign legibly and sign your whole name. It must support what you're doing. It must say what's going on. That's Smokey Robinson singing, "What's going on?" It's really not Smokey Robinson, but nobody here knows. You're all too young. It's the one that's the guy that sings, but he's not Smokey Robinson. What's going on? What? Marvin Gaye. It is. It's Marvin Gaye. They always get me on that one. What's going on? I do a lot of research, but not so much in that part. Not as much. Not as much for that part. I can't believe that came out of my mouth. You must give the precise location. Now, your ICD-10 code says that it's a lumbar on the HCFA form, but in your notes, you must say it's L3. If it's sacrum, you can have M99.04. But everything else, it has to give the precise level. The precise level. Each daily note, you must say it. You must give by region when you charge. There are 5 regions. So M99.00 is the occiput. That is the same region as the neck. So if you adjust the occiput and C2, that's one region. All of the rib subluxations are part of the back. Now, they don't say thoracic spine. They say back. I don't know why. But that's what they have. So if you adjust the angle of the rib, the costochondral, and an anterior T3, that's one region. The rest almost makes sense. Usually I lecture with a pith helmet on because Medicare is so unlike the rest of insurance that if I have the helmet on, I'm talking Medicare only, Medicare only, Medicare only. Because what they say, like box 14, date of illness, injury, LMP, everybody else it is, but Medicare, it's the date of first treatment. Sacrum and pelvis, if you have a sciatic patient and you adjust L3 and the sacrum and a left PI ilium, that's a 98941 because that's 3 regions. That's 3 regions. History. You have to go through a case history. Symptoms. A history of the symptoms. Family history if it's relevant. Past health history. And the mechanism of trauma now. Are they doing, they're up to now, you got, what about onset, duration, intensity, frequency? Then you are golden. Better than most practitioners out there. Mechanism of trauma is only if there was trauma. It's not a required. I have people, oh, they're going to take back all the money for incident of trauma. No, just if there is. Prior interventions, treatments, and secondary complaints. Secondary complaints are important because if you're going to bill for 5 regions and they only have 1 complaint, you need a complaint for each region, or you can't bill for 5. It's not accurate. The initial visit, you must have a special examination. You have to give the location of pain. And you must have a statement from that initial visit examination that the subluxation in question is capable of causing the symptom. It must be written out. It must be a statement. Nobody else does this. Are we getting ridiculous? Nobody else does this. But if you have a line that you circle that says, is the vertebra capable of causing pain in the area examined? And there's a yes and a no, circle the yes, and you're golden. And you're golden. It is that easy. It is that easy. But when I opened practice, you could have a cervical subluxation for sciatica. And that makes sense for an HIO or a Blair practitioner. Medicare didn't understand that. So they want you to have a statement saying, your clinical judgment, it's capable of causing pain. I spent 45 minutes in counseling on the phone this afternoon with a fellow that's got about $120,000 in Medicare that they're looking at because his documentation isn't up to snuff. Not once has he ever written out that the vertebra is capable. That is not good. That is not good. So, know the rules. They're not that tough. They're not that tough. And it's been taking a lot of counseling for him. You must go through evaluation. It should be a regular musculoskeletal exam going by your clinical judgment. Make sure to have vital signs, any applicable orthopedic and neurological, and review for contraindications of treatment. The LCD gives the actual things they want to look for. What's contraindicated? Well, there's a conditional contraindication, like if they were on blood thinners or if they have an arthropathy. And an absolute contraindication if they have a tumorous pathology of the spine. Make sure of that. And just say no contraindications or that you reviewed for contraindications. Give the diagnoses. Primary, always M99 point something. Secondary, it's a pain, it's a complaint. Tertiary is a somebody say complication. A complication. It might be end plate irregularity, degenerative joint disease, spinal stenosis, could be Parkinson's, or the inability to stop reciting poetry when everybody else wants them. L463510. Diagnoses. The exact level of subluxation relating to the diagnosis. So it has to be M99.01 if it's a cervical. Have it in your notes, the exact subluxation. Treatment plan. They want duration and frequency. Looks pretty easy. Duration and frequency. They want more than duration and frequency, but we're going to start with duration and frequency. When they ask for a treatment plan, this is what they're talking about. They want the date of first treatment. So go to the box that says date of first treatment. On the HCFA form, there isn't any. But box 14, date of illness injury, or LMP. Mandatory claim submission. Dave, I'm sick of this. I'm going to just have them come in and pay. They'll never catch me. I'll never go to jail. They will. They will catch you. Somebody's going to pay for 3 years, and then their niece is going to say, oh, well, don't you know Medicare covers? And then they call, oh, yeah, we cover chiropractic. And then they'll want all that back, and they'll want it sent in, and you'll get in trouble. So don't do that. Medicare covered services must be submitted for the patient on the form, and it has to be you can't say, well, it was soft tissue. You have to give what it is. Non-covered services, you're not required to submit them unless the patient requests. Opt-out provision. If you're a certified nurse midwife, are you allowed to opt out of Medicare? Yes, you are. If you're a DO, yes, you are. If you're an MD, if you are a DPN, if you're a podiatrist, and they're like the mimes of the clown world, if you're a podiatrist, rodeo clowns are at the top. If you're a podiatrist, you may opt out of Medicare, but chiropractors cannot. We don't have the political clout, and ACA and ICA, there's bigger fish to fry. So you can't opt out. Opting out is really not, I've read the background of it. I wouldn't opt out even if we were allowed. But because you can't opt out, cannot opt out, document well. When it's maintenance, it's maintenance. When it's active treatment, be paid for it. You cannot opt out. So, your treatment plan, you need the level of care. You need duration and frequency. You need specific treatment goals. Is this beyond you? I was in a meeting with At that time, Highmark Blue Shield ran the program. They kept changing their name. Highmark Medicare Services, from Exact Medicare Services, from HGS Administrators. Whenever they got caught in one fraud, they started just another company and got the contract back. A true story. They can't sue me for it because it's the truth. And usually I have somebody from the insurance company right here, so I make sure to have all the references right there. What are you looking for in your treatment plan? What are your goals? And the medical head looked at me and says that they don't have as much pain. Give me some other things. But yeah, getting their pain under a verbal rating scale of 3 is a pretty good idea. So I always start with the verbal rating scale, and they love to have a function. What's a function? Oh, well, I can't babysit Brittany anymore. I live in the Pennsylvania Dutch area. I can't babysit my niece or my granddaughter, Brittany, anymore. I can't take her to the store. And it's Brittany, Britnee, and that French accent over it. You've seen it, that kind of Brittany. And in 3 weeks, when she can and she's able to shop on her own and she has those skills, the administrative law judge really likes that. And I found, after doing that, because I was doing that kind of crap because the administrative law judge really likes that, your actual treatment and your relations to the patients improves. I hate to admit that. It's tearing my heart out. But it really does. So put in some functional things, especially to do with their activities of daily living. Objective measures to evaluate treatment, say what you're going to use. We all have things that we fall on, even if it's just leg length discrepancy. Range of motion, activities of daily living, Oswestry questionnaires, functional rating index, patient-specific functional scale. You can Google any of these and they'll come up. Say what you're going to use. You don't have to use them every time, but overall, tell Medicare, this is how I'm going to evaluate. After the initial visit sets the stage for your next 30 or 15 or whatever you're going to take. Each time they come in, review the chief complaint. It says history, but this is more or less subjective. And then the changes in the subjective. They want to be able to see per visit the overall and what's going on with the patient. Don't send in that visit and say, oh yeah, but you got to go back to their initial blah, 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 blah. No, no, no. They want all of it seen right then. So you need the subjective, change in subjective, and if relevant, give a system review. Then go to the objective, the physical exam, the part of the spine involved in the diagnosis. You don't have to do the whole body, just the parts involved. Assessment of the change in the physical findings. Subjective, change, and subjective. Objective, change, and objective. Give an assessment and evaluate the treatment effectiveness. Every time you have to say, is treatment effective or not? So you have a little box. Is treatment effective? Yes, no. I always circle yes. Except when they're ready for maintenance care. Then I circle no. You mean maintenance isn't effective? By Medicare's definition, it's not. Instead, it's a treatment plan to enhance the quality of life and maximize their performance. So it is not a burden. It's not more than what you can do. Document the treatment was given. Record what level on that date and that it was given, and sign your name. If you don't sign your name, if you don't say it was done, it wasn't done, and they get their money back, and they get all of it back. So they want to know that the service was done at the level of complexity indicated. Don't give 5 regions when it really wasn't 5 regions. Was it medically necessary to give all those? Now, I am a full spine adjuster. If they come in for sciatic, and I document sciatic, but I have a subluxation in the ilium, the sacrum, T3, T4, and atlas, I get to adjust them all. But the others I don't charge for because they were incidental to the primary service. Medicare pays me $98940 because it was the sciatic and the lumbar that I did. Now, if it's a more complicated sciatic, so let's say there's a lumbar subluxation that's giving low back pain, and then the sciatic with radiation and a complication of stenosis, I will have lumbar diagnosis followed by sciatic diagnosis, followed by sacrum, followed by low back pain diagnosis, followed by ilium, followed by stenosis. So that's the only time I would bill a 98941, even though there's only one symptom, which really is more than one, and a complication. Abbreviations are allowed for all documentation as long as there's a legend to decipher. The legend must be available on request, and it must be sent with any documentation. So I go through acceptable notes and what things are on, and then people learn how they can get paid. This is the wording they use, and it's online when you go to Palmetto GBA, what they have to sign to give benefits over to you. Does anybody, this is how to fill out the HCFA form. There's different boxes, date of first treatment goes, documentation of the subluxation. Why are they denied? Lack of documentation. 93% on the OIG a decade ago were found to be lacking the full documentation. I go to the meetings of all the specialties for Medicare, and they always criticize the chiropractors. And then when I show them what the documentation requirements are, the surgeons stand there with the mouth open. The physical therapists say, oh, I'm really glad I'm not a chiropractor. Because, am I right? Do we have the most ridiculous documentation requirements? Every time you have to write the date in your chart, the date of first treatment, writing the diagnoses all over again, originally, and then how many treatments for that condition. And that's before you get subjective change and subjective objective. Change and objective. Assessment was the evaluation of whether or not it's effective. The exact levels, treatment was given, sign your name, and the care plan for when they come in again. But I can do all that. Now, if you do it and you're in practice, it'll take you about 90 seconds, maybe 2 minutes. Once you get in the habit and you have all those check boxes, under 45 seconds for your documentation. I see a lot of patients in the morning, a lot of Medicare. But you guys, you never got up early enough to come in the morning, did you? You did? You were in for morning patients? All those old people? Okay. All right. No AT modifier, everybody's over that. Not a valid diagnosis. What's a valid diagnosis? It's on the local coverage determination. If it's an invalid date of x-ray, you can have an x-ray as long as it's within a year of the date of first treatment. Really, if there's a permanency like a spondylolisthesis or a scoliosis, it's good for 5 years. But if you have it from 5 years, you have to send in your documentation every time. So I either do a physical exam or I retake the x-ray if they're more than a year under care. Or not medically necessary, you know all those definitions. There's some myths, GA modifier, blah, blah, blah. Bottom line, document and bill if it's active treatment. They're paying $124 a month for Medicare Part B. Medicare Part A is free, but Medicare Part B is more than $100 a month they're paying. If it really is active treatment, let Medicare pay for it. And when they're ready to go to maintenance, believe me, this is the wealthiest demographic in America. They've got the most land, and they don't act like it. Well, now the ones that went through the Depression, they're dying off. The baby boomers coming on, they're a lot more liberal with how they throw money around. But they have the benefits. You should let them pay for it. Maintenance care, it's not covered, and it need not be submitted. What's the one situation where you have to submit maintenance care? One, if the patient requests. If they request, that's when you have to send it in. Send in the notes for medical necessity when it's required by, in my area, Navitas or Novitas Solutions. If denied, appeal at every level. You will win. You will win. Take those notes. Before I go into questions, why'd you come down to see me today?
Learn more about Medicare.
Okay, and whether or not it should be used? Good. Any other comments on why you're here or what insurance? Because I want to answer what's going on for you. Then let's go into Medicare. Once again, you know my prejudices. My prejudices are they paid for it, they have good coverage, and it's very clear. No other insurance company is as clear on what their requirements are and how to get a hold of those requirements. The floor is open. You're on the air, caller. It's always the first. I should have put a plant. I should have put a plant in to ask. Annabelle Lee really did exist. Edgar Allan Poe never got over her. She died of consumption. You guys know it as tuberculosis. That's right. That's right. R264 point. Okay, where do you get the ICD-10 codes? Where do you find them that they're free? CMS.gov. And it's in a tabular list. It's a download that all you do is hit Control F and put in what you're looking for. Sciatic. Every time sciatic is in there, it just comes right up. It's amazing. Go ahead.
Is there a way we can see an example what this form looks like?
Yes. Yes, I have that. I can bring that right up. Any questions on anything? You mean the Medicare checkbox form that I use? Yeah, okay. I can do that. Oh, great. So as I'm shuffling around, you guys will see me not getting to the right person. DePici info, new volume. I think it's going to be easier to find someplace else. It's best to have a lot of this over and over again. All right, Dr. Tom, how do I make this a single page? Layout? How about view? Whoa! No, that didn't work. Bottom right?
Yep.
Right there? Zoom or?
Yep, Zoom. So it's probably 80%.
Well, but it's in a two-page thing.
There you go.
Oh, wow. Holy cow. What will they think of next? Oh, there'll never be another hula hoop. So, this is the initial Medicare exam. I get all of it on one page. And, oh, this doesn't have a page down. That's right. Initial Medicare exam. You need the name, your name and address, and I put my NPI number on it as well. Dates on the right, initial Medicare patient history. You have a lot more room on your regular form. This is for the physical exam. So you'll briefly give a synopsis of the general health status, past health history, date of injury. Date of injury does not go on the HCFA form at all. Date of first treatment does. Date of injury only goes in your notes. Family medical history, mother, did she have cancer, diabetes, heart disease, or hypertension? What age did she die if she did die? Father, the same thing. Pain symptoms, what do they want? They want the quality, the onset, the duration, the frequency. I go by IOCF, I-O-C-F. Intermittent, occasional, frequent, or constant. Constant, 75 to 100% of waking time. You guys know what I'm talking about? Yeah? Okay, all right, good. There's a lot of that don't. Intensity, verbal rating scale. 2001, the Journal of Neurology published an article saying verbal rating scale, 0 to 10, all you have to do is talk to you, and that's valid. If you use the visual analog scale, you need a 10-centimeter line that they have to put a check mark on every time. But the verbal rating scale, you can ask. What's the location of the pain? Does it radiate? What makes it worse? What makes it better? Is there any mechanism of trauma? Are there prior treatments and doctors and medications? Are there any secondary complaints? Vital signs. At one time, at one time, all of those tests were required. You needed one neurovascular test. You needed one deep tendon reflex. You needed all 12 cranial nerves. You needed one sensory test. You needed one motor test. And you needed at least one orthopedic test for that region. They don't do that anymore. But I still use that form because there were so many times that it was valid that I really did want some of this, because you're dealing with older and more fragile people, that I do keep it there. The cranial nerves aren't that difficult. You just keep some coffee in your little bag and have them do blah blah and make them smile and put your fingers over their eyes and stuff like that. Then I'm going to show whether it's an acute subluxation or a chronic subluxation. I'm going to circle the one that it is. 9 out of 10 are chronic. Most of my patients, when I develop their x-rays, I find that they're chronic. I'm going to give the diagnoses M99.01 and then an M53.1. Anybody know what an M53.1 is? Cervicobrachial syndrome. Cervicobrachial syndrome. So that's going to give me a start there. And then the assessment, I'm going to write it out. I'm going to say cervicobrachial syndrome into the right upper extremity. Secondary to a chronic subluxation is C5 posterior. Now I do that in shorthand. And during the warm-up, I showed you some of the shorthand. Plan of treatment, the frequency, how many days a week. Duration, how many weeks. Almost always it's 3 times a week for 3 weeks and a re-exam. Why? They're old. So I tend to reassess at 3 weeks. That's my preference. You can do whatever you want, but that's my preference. Criteria for evaluation. I can use range of motion, verbal rating scale. Other, I frequently write down ADLs for activities of daily living. And the judge likes to see you write stuff in at times. By the way, there was a subluxation with nerve impingement, and it was at blah, blah, blah. What are my goals? VRS less than able to babysit Brittany. It looks like Brittany, but no, it's pronounced Brittany. Vertebra is capable of producing. Am I going to circle yes or am I going to circle no? Yeah. What's the date of the x-ray? And the date of the x-ray goes on box 19 on the HCFA form. Because box 21 has the date of first box 14 has the date of first treatment, and I have to have those within 1 calendar year. Now, at the bottom, I have more room, not more detail. On the bottom, I have more room to give objective findings. It's just a regular physical exam. And adjustment administered to, that's going to say C5 posterior, L4BL. Treatment ordered by my legible signature. So it was administered and it was by me. It's phase 1 because I adjust on the first visit. If you don't adjust on the first visit, then you have to say the anticipated date of first treatment. And my plan, I'm going to see him in 2 days or 4 days or whatever. I have a more definite plan up higher. 98940, if it's active treatment, what do I write on that line? If it's 98941, an active treatment, what do I write? If it's 98942, what am I going to do? I don't have it written there. That's how infrequently there's medical necessity for 5 regions. 5% of my patients, I've been called in to help with cases that they've got 7 years of billing only 98940. $360,000. You take $360,000 from the federal government in payment, you should know what the documentation requirements are. Couldn't help him. Couldn't help him. Don't call me after the parachute didn't open. So, it is that rare. I want to make sure, I didn't say anybody's name though, right? Okay. I want to make sure that I don't by accident bill a 98942. It is rare for any insurance company to have medical necessity for all 5 regions. They pay freely, but then they also ask for it back. That's what I need. That's longer than 90 seconds. It's the other ones that are only 90 seconds. That's what I need. Now, it's not a covered service, so what's your fee schedule for this 99202 or 99203? That's right, whatever the market can take. And it is the most wealthy. It's the demographic with the most wealth. It's the demographic with the most wealth. Charge your regular fee. Your fee is your fee is your fee. Don't change it for people. Don't change it. In my state, it's illegal to have it vary in my state. But my fee is my fee is my fee. Even if they bring, well, sometimes if they bring me cookies, I'll knock off. Remember the woman with the peanut butter fudge? She passed away. Oh, she was great. Yeah, I know. It really hurts. So, 99202, it's the full fee. The same way it is as it is with maintenance. Any questions on this initial exam? You guys can knock it out just like that, because I expect they're doing more than that at the clinic. They're doing more than that. There's a list of absolute and relative. I also suffer from lethologica, where you can't think of the right word. What's the contraindications? There we go. Contraindications. Relative and absolute. They don't want you to adjust over a tumorous pathology, a cancerous pathology. Here's my daily note. Looks like this. But when I walk in the room, Kim has it, also known as Aunt Kim. She has it that already on the left column, see how there's a date and date of first treatment? And I haven't updated this yet. Those are the old ICD-9 codes. The initial diagnosis and an x-ray date. And how many visits have I seen this patient? Phase 12. I've seen them 11. Treated them 11. This is treatment number 12. CO, complains of. I'm going to say what it is. I'm going to give the verbal rating scale. I'm going to go for the, what's the pyramid mean? Change. Delta. Change. Delta. Subjective, change in subjective. Oh, by the way, the verbal rating scale, if it was a 6, then I ask how much of your waking time. If it's 50 to 75% of their waking time, it's a 6F. F for frequent. F for frequent. Objective, this is all in shorthand for me. I have an arrow pointing up. CT, T2P. The arrow up is increased. CT is cervicothoracic. And uppercase T, Arabic number 2, and uppercase P, tenderness to palpation. Then I'll say where they have trigger points. And then I'll go and I'll give the changes in that. How do I know what the changes are? I look to the previous visit and I compare them. It might be an arrow down and TRP for fewer trigger points. It might be an arrow up. It might be more function, less function. But that's all you have to do to show a change. I'm going to give an assessment. If they're the same as previous, I'll circle SAP. But if there's a change, if there's a delta, I'm going to say what it is. And that's for the, more tenderness, less tenderness, da-da-da-da-da-da. Is the treatment effective if it's active treatment? Yes. Give the vertebrae you adjust. Sign your name. Sign if it's an acute, a chronic, or an exacerbation. And then plan. If it's pro re nata, they come in as they please. I'll circle it, and that means they're going to be next time in maintenance. But otherwise, I'm going to put like 3D or 4D, 3 days or 4 days, so Kim knows when to schedule him. And then I'm going to put an AT beside which one of those are accurate. That's a routine visit. That's a routine visit. Any questions on that? What happens if they got hurt? They were doing really well, and then they fell down the stairs. Will Medicare pay if they got hurt and they can't function as well? It's called an exacerbation if I'm still treating them. But if it's been quiescent for 90 days, then we've got a recurrence. So if they have an exacerbation, I'm going to circle exacerbation on the top right so Kim knows we're going to have a change. I'm going to put a single strike through the date of first treatment. I'm going to put a single strike through that you can still see that it says 6/21/2008. A single strike, and I'm going to write beside it 9/18/2008 because the date of first treatment becomes today. Under subjective, I'm going to find out when they were hurt and get more detail, and that's the date of injury. but the date of injury never goes Medicare only. Oh, I don't have my helmet. Medicare only, date of injury only goes in your notes. It never goes on the HCFA. It never goes on the form that you send in. Kim knows, because I circled exacerbation, she has to change in the computer the date of first treatment. And then I'll probably have an additional diagnosis. It'll probably be an S43.2 XXA. It'll be a sprain or strain code. It'll be a sprain or strain code. And then I'm going to circle exacerbation of a chronic subluxation there. That might take me 90 seconds because it's new and different. It won't be the 45 seconds. Electronic healthcare records, I've had many people tell me that they can set up their electronic like this, their EHR like this, that they have the power to bring that up in like a matrix, but they have to make the changes. It doesn't come from the company that way. It doesn't come from the company that way. Exacerbation, then you start the counter all over again. Underneath plan, I'm going to see him in 3 days, and I'll write 1 of 6 anticipated treatments. In the literature, in the past, in my state, they gave as an example an exacerbation would be 6 more treatments. Pretty good rule of thumb. Clinically, if I see something that I know it's going to take more than 6, I might write 1 of 8 anticipated treatments. But that's usually somebody with, say, a double scoliosis, or somebody that's already on disability, or as I mentioned, Parkinson's, or a condition like that. Okay, I have gone on very, very long. If there's, I will entertain another question. Otherwise, I'm going to end the formal part, and then people will come up and ask what they really want to ask, because I do have a great tattoo story. Are there any other questions? All right, thank me for coming out. It's a blast to come down to Sherman College. Woohoo!